Good evening, everyone. Thank you so much for joining us. We're going to give everyone a moment or two to log on, and we'll begin shortly. Okay, good evening, everyone. Thank you for joining us tonight. We are so pleased to present In the Middle, Menopause and Mood. It's not just in your head. It is now my pleasure to turn things over to Dr. Susan Loeb.
Thank you so much. And thank you all so much for joining us this evening. So when you think of perimenopause, the years leading up to menopause, you may think of the common symptoms that you've heard of: hot flashes, night sweats, maybe weight gain, insomnia, hair, skin changes. You also might think of menstrual irregularities and the eventual end of the periods. But many people experience mood symptoms during this time of their life. The mood changes can have impacts on women's quality of life, productivity, and physical health. And based on the huge response we received for this webinar, this clearly is a concern for many women. The hormone changes that affect your periods during perimenopause can affect your emotions too. And the physical menopause symptoms that I mentioned can lead to stress, fatigue, and intensifying emotions. Also, these changes occur at a time of a woman's life when pressures can be the greatest. Many people in this age group are managing demanding jobs, raising younger children, or sending older children off to college or into the real world, and caring for aging parents. All of this stress can add to mental health challenges. This can be referred to as the sandwich generation, or as my friends like to say, the silly putty generation, where we are pulled in so many different directions. So we will delve into all of this more deeply this evening, discuss mood changes that occur during perimenopause and menopause, and what we can do to help ourselves during this time. So I am thrilled and honored to be here this evening with Dr. Lauren Osborne. Dr. Osborne graduated from Weill Cornell Medicine and received her training at Columbia University, New York State Psychiatric Institute. She completed both clinical and research fellowships in women's mental health and is an expert on the diagnosis and treatment of mood and anxiety disorders during pregnancy, the postpartum, the premenstrual period, and perimenopause. Dr. Osborne serves as the Vice Chair of Clinical Research in our department, the Department of OBGYN at Weill Cornell Medicine. She has an impressive resume with research and clinical work in the care of women during their reproductive years, and has been an incredible addition to our department. So thank you, Dr. Osborne, for being here with me this evening.
Thank you so much. I'm really delighted to be here, having come home to Weill Cornell after some parts and times in distant lands.
Great. So why don't we just get started? I mentioned it briefly in the introduction, but why does this happen? Why do women during perimenopause and menopause have mood changes? What's going on physiologically?
Yeah, so it's really interesting. I think people like to cling to the explanation of it's hormones, right? And of course it is hormones, but it's not just a simplistic relationship of a change in hormone that leads to a change in mood. What we have in the perimenopause is constant fluctuation of hormones. So across a normal menstrual cycle, the hormones rise gradually, they fall gradually, the cycle repeats itself like clockwork around the year. In the perimenopause, there's constant rising and falling of hormones. And some women are really vulnerable to that fluctuation in hormones. So it's not the actual levels of hormones themselves, but that fluctuation can really lead to changes in mood.
Yeah, we see that. And that's why sometimes as you get into menopause, when the estrogen levels level off again, these symptoms can improve, right?
Exactly. So we know that, it's a commonly cited statistic that during the reproductive years, women have twice the rate of depression compared to men. And you can see that very clearly. It's when girls enter puberty, suddenly that rate skyrockets up to twice the level of boys, stays elevated all through the reproductive years, has this real spike in the perimenopause when those hormones are fluctuating. But then significantly after postmenopause, women's rate of depression actually drops to below that of men. So we can tell that there's something going on with that hormonal milieu.
So interesting. And we know that there are estrogen receptors in the part of the brain that is involved with mood and cognition, right? So it makes sense that as these levels are going up and down, it's going to affect that for some women. Yeah.
Exactly. Estrogen has a lot of potent properties. Among them, it's anti-inflammatory, and there are estrogen receptors that interact with all of the neurotransmitters in the brain. So it makes perfect sense that as you start removing or fluctuating estrogen, that you're going to have those issues. But it's not just estrogen, it's progesterone as well. A lot of the metabolites of progesterone are very strong anxiolytic molecules, so they make people calm. And once you start fluctuating that estrogen, you're having peaks and troughs in that progesterone, you're having peaks and troughs there that can lead to spikes in mood.
Yeah. Interesting. So, and the title of this webinar was "It's Not Just in Your Head." So it's more than just what's going on in the brain. As I mentioned in the introduction, it's also everything else going on in our lives at this time that contributes to these mood changes too. Correct?
Absolutely. And I think that, I do biological research, so I tend to focus a lot on the biological explanations, but we have to remember that the biological and the psychosocial are combined, right? So biologically, you have these changes going on in your brain. You have other biological changes in your body, like vasomotor symptoms, like sleep disturbance, which of course, both of those can contribute to depression or be independent of it. You have body image issues, weight changes in the perimenopause, and a lot of people can have difficulty with that. And then you have the purely psychosocial issues, like what you mentioned with the silly putty generation, with the huge amounts of responsibility that's on midlife women, and you combine that with what's going on biologically, and that can lead to trouble for some people.
Yeah, I think you brought up a really good point, because I think for sure other menopausal symptoms are impacting our mood. We feel lousy when we have a hot flash, when we're not sleeping. But also, we know that women have changes in their sexual health during this time. That doesn't feel good either. And that certainly can affect their mood.
Absolutely. There's significant changes in sexual functioning, and and that can be something that changes your relationship, and that can have further effects on your mood. So absolutely, all of those things intertwine.
So it's so complicated. There's so much to talk about. So do you have an idea of what percentage of menopausal women will experience something like this?
Yeah, it's actually a little bit hard to get your hands on that number. The commonly cited number is about 4 in 10 women will experience mood changes as part of the menopausal transition. But it's really different depending on what other risk factors you have. And experiencing mood changes or mood swings isn't the same thing as experiencing depression, right? So and your rates of actually developing depression are very different depending on what your other risk factors are.
We're going to get into that for sure. So let's start with sort of back in our earlier reproductive years, a lot of women had PMS symptoms, right? How does this relate to that?
Great question. So what we know with any type of what I like to call reproductive depression, which is a term that was coined by a mentor of mine a number of years ago, by which she means a depression that's associated with some kind of reproductive transition, right? So women who are vulnerable to any kind of reproductive depression are vulnerable to other kinds of reproductive depression. So that means if you are somebody who had mood changes when you first got your period, you have PMS or mood changes in the premenstrual period, you experience postpartum depression, you are a person who's vulnerable to that reproductive subtype of depression. And we know, as I said before, it's not the levels of hormones, but it's a unique vulnerability that some people have, which probably has to do with genetic differences or epigenetic changes or other things that we haven't quite identified. So if you're somebody who experienced PMS, unfortunately, that does put you at higher risk of experiencing mood changes in the perimenopause.
Yeah.
And the difficulty with that is that when you have PMS, at least it's on a cycle, right? When that luteal phase, the second 2 weeks of your menstrual cycle, when that's coming, when you're going to get your period for people who have regular cycles, and you can know when those mood changes are coming. In the perimenopause, it's like this, and you can't tell.
Right, because your cycles will vary in length, just
Mhm.
and so you can't rely on that for sure. So there are mood swings and then there's depression. So what's the difference?
Yeah, great question. And it's something that I encounter a lot with patients, particularly with patients who have had a mood disorder. And then let's say they come in and they've had a really bad day and they're feeling sad that day. Patients will worry, does this mean I'm depressed? Well, no, not necessarily, right? Everybody has days where their mood is up or down. Everybody has days that are where they feel sad or blue. That doesn't mean depression. What depression is a loose constellation of symptoms that you have to have experienced for at least 2 weeks in a row to call it an episode of depression. And I'll list what those symptoms are, but I want to first emphasize that for me, what's really important to distinguish an episode of depression from somebody going through a rough time is, does it affect your functioning, right? So if you are feeling low, but you're still able to do everything you're able to do, and you can take care of yourself and you can take care of the people around you and you can go to work, that's not affecting your functioning. If you have a depressive episode, it is going to affect your functioning in some way. It's going to affect the way you interact with your partner. It's going to affect your ability to have focus and concentration at work. And the symptoms that we look at are changes in sleep, changes in your level of interest in things. Do you take pleasure in things? Can you enjoy the things you used to enjoy? Feelings of guilt, low energy, poor concentration, changes in appetite. For some people, that means low appetite. For some people, it means an increased appetite. What we call psychomotor changes, so feeling slowed down, not moving as fast as you usually do. And then, of course, the big one, suicidality, having feelings of not wanting to be alive. And you have to have a constellation of at least 5 of those symptoms for at least 2 weeks to call it an episode of depression.
But if you're experiencing those things and they're going on for 2 weeks, maybe it's a good time to reach out to your provider, right?
Absolutely, absolutely. Mm-hmm.
So like the loss of appetite, the lack of sleep, or or the opposite, not able to get up in the morning and go to work and not functioning at work. If that's going on for more than just like a bad day and
Exactly.
lingering.
And one of the things that makes this challenging in the perimenopause, of course, is that some of those symptoms of depression are actually the same as some symptoms that are related to physical symptoms of menopause. So, for example, concentration difficulties, which are one of the hallmarks of depression. Well, there are cognitive changes that occur to women in perimenopause and that may give people concentration difficulties, even if they're not depressed, right? And so we have to remember that. But we also have to remember that while these things can coexist, they can always exist separately. But if you're not sure, it's great to seek advice from a professional.
And we'll get to treatment later, but the treatment for both of those things might be similar anyway.
Absolutely.
Yeah. So yeah, definitely. This is really important to bring up to your provider because again, it's such a busy time in our lives. We can't be feeling this way. So there are things we can do. Right. All right. So for feeling depressed, this is a question that came to us through one of the participants. Should we be checked for anything else? I know thyroid disease is one of the things, but what else should we be checked for to make sure nothing else is going on and that it's just depression?
Yeah, I think that's a great question. And thyroid disease, very much something we should check for. Thyroid dysfunction is common in midlife, and low thyroid can be associated with, can present similarly to symptoms of depression. And on the converse, high thyroid can present with some of the same symptoms as anxiety, which is very comorbid with depression in this period. But there are a couple of other things that I always check for. One is if it's somebody who's having a new depression and we haven't seen depression in that person before, I check levels of vitamin B12 and vitamin D, because both of those can be associated with low mood and they are reversible medical causes of depression. So the number of people with vitamin D insufficiency in this country is actually extremely low, especially women. Extremely high number. They have very low levels. So that's something to always check. And vitamin B12 also can often be deficient. And so those are things that I easily check. The other thing to do is we as providers always have to remember to ask about lifestyle factors that might be affecting patients' symptoms. So the use of substances, and when I use the word substance, I don't just mean illegal substances. I mean things that people use commonly every day, alcohol for one, but even caffeine. Caffeine withdrawal can feel a lot like anxiety. Alcohol withdrawal also can feel that way. And so we tend, as providers, I think, to shy away from asking that question, but particularly if you're trying to suss out what are mood symptoms, what might be physical symptoms, or what might be a third cause, that's a really important thing to always ask about.
Yeah, and the physical symptoms can lead to the mood symptoms, and the mood symptoms can lead to the physical symptoms too. And so they all work together also, right? So a question that really frequently comes up, in fact, we talked about it before, is do I need to have my hormones checked? And I'll just answer that one. It's not really very helpful to check hormones. We know, as Dr. Osborne has already said, during perimenopause, they're fluctuating. So in most circumstances, checking hormones on a given day is not really helpful for us. Of course, there are circumstances where it makes sense. If you're 36 and going through this, well, maybe it makes sense then. And there are other situations too. But we really treat symptoms, take a good history, and not treat the blood tests with regards to hormones.
Yeah, I 100% agree. And when you think about that fluctuation that I said, things are going up and down like this all the way through the perimenopause, that means if we did draw your blood and check your hormones, one day the hormones might be really high and the next day they might be really low. And that's really not telling me anything about that change, that one-time spot check. And I know a lot of people would like to check hormones because they're trying to find a physical cause for what they're going through. And that physical cause is there, that biology is there, but checking the level of the hormone isn't going to help us get to it.
Right. So again, it's really common. It's really something to bring up. And we talked a little bit about who's at risk. If you have had other reproductive depression or mental health episodes, postpartum, premenstrual, that definitely is at risk. But what else? What other comorbidities or other racial differences?
Yeah, great question. We know that in addition to the reproductive depression, people who've had any other kind of mental health history in the past, any other episodes of depression or times of anxiety in the past, that puts people at increased risk. But in addition, there do seem to be some other clear risk factors associated. For example, people who've had high rates of adverse childhood experiences, or what we call ACEs, so early life trauma, you're at much increased risk of depression in the menopausal transition if you've had that kind of early childhood trauma. In addition, people who've had a high number of upsetting life events recently or high stress in their life, that puts people at much higher risk going into the menopausal transition. People with higher BMI are at higher risk for mood symptoms in the perimenopause. People with lower education or lower levels of social support are at higher risk. And also people who enter that menopausal transition at a younger age. So and you can think about that as, the younger you are when you enter it, you're not only experiencing the biological, but you may be experiencing a loss of what you thought was going to continue as your reproductive life. So those are all well-known risk factors. People who have high rates of vasomotor symptoms or sleep disturbance, they're at higher risk of developing depression. And then there are some studies that do show differences in different racial groups, but those studies don't necessarily all agree with one another. And in addition, we don't know if there are differences in terms of racial groups. We don't know if that has come about because of differences that have to do with a person's race, which is a social construct after all, or because of other things that are different in people of different racial groups, things like income, education, socioeconomic status. So I think those data are kind of fuzzy.
Yeah, it's interesting though. Good to look at so we can be more aware when we're taking care of our patients.
Exactly.
Does depression during menopause run in families? If my mom had it, will I have it too?
Great question. And unfortunately, there is a familial link. Absolutely. Having a family history of somebody who experienced a perimenopausal depression does put you at higher risk.
Yeah. So we've talked a fair amount about depression. We threw in some anxiety, but we didn't really talk about the symptoms of anxiety and how that differs. And so what, because that's also increased during this time, right?
Absolutely, it's increased. And there's some interesting studies that show that people who had anxiety all their lives will experience anxiety in the menopausal transition that may just be a continuation of their usual anxiety. But even women who didn't have anxiety earlier in life are at risk of an exacerbation or a beginning of anxiety in the menopausal transition, unfortunately. And those symptoms of anxiety are really easy to conflate with symptoms of physical disorders. And so I think a lot of people overlook them or don't realize that what they're experiencing is anxiety. So we think of anxiety as fear or terror or worry, right? And so those psychological symptoms of anxiety definitely exist, but there are a lot of physical things that go along with anxiety. So for example, breathing rapidly, sweating, trembling, feeling weak or tired, feeling like you're having heart palpitations, having trouble concentrating, having trouble sleeping, having GI symptoms, nausea or other GI kind of disturbance. Those all feel like very physical symptoms, and they are symptoms of anxiety. They may also be symptoms of other physical illnesses. And so I think a lot of people don't think to connect them to anxiety.
Yeah, but it's real. And it's interesting how you say if you had it, it might get worse, but it's also can be new during this time period, right?
Yes, exactly.
Yeah. And then there are other mental health issues related to anxiety, such as OCD, right? That might also increase during this time too, I would assume, right?
Absolutely. And the research on OCD exacerbations in the menopausal transition is not very robust. We haven't done a lot of research in it, but because OCD is related to anxiety disorders, we know that anxiety can be exacerbated. We think that OCD likely can be as well. And there's a fair amount of information about OCD at other times of reproductive transition. So at the time when a girl first gets her period, that's often a time of first onset for OCD. The postpartum period, there's recently been a new study that came out that showed that the rate of OCD in the postpartum is about 17%, many times higher than we used to think that it was. And so I'm convinced that that number is probably similar in the menopausal transition. We just don't have the research to back it up at this point.
That's a high number. I had no idea. Wow. Okay, so it's really important for us as providers to be on the lookout for that too.
Absolutely. And I think there's a lot of misunderstanding in the world about what OCD is. People tend to think of OCD as, you're somebody who you like all your colors lined up in your closet, or you're very picky about things. That's not OCD. That's a neat nick, right? OCD is a real serious psychiatric illness that includes intrusive thoughts, which we call obsessions, an intrusive thought that pops into your mind that you can't get rid of it, and you experience significant distress from it. And then a compulsion, which can be a physical or a mental ritual that you engage in to decrease the distress of that intrusive thought. And one of the things that I think a lot of people don't recognize is, let's say you're having an intrusive thought about your health. That's a common worry for OCD in the menopausal transition. You're experiencing physical changes. You get an intrusive thought that this means you have cancer or some other, terrible physical illness. And let's say what you do is you compulsively Google about it and look up a lot of different websites. That's a compulsion, right? So that may be OCD. And it's something that you really have to bring to the attention of a provider.
So we're going to talk about what we can do about all of these mood disorders. Is there something different for OCD than the rest of the?
So great question. We treat OCD. There's a specific type of psychotherapy that's really effective in OCD, and it's a type of cognitive behavioral therapy that is not just cognitive behavioral therapy, but it has an added component where it's called exposure therapy, where we expose people to the things that they have fears of or are having these intrusive thoughts about in a graded way to sort of gradually get them used to that exposure. And that's kind of the gold standard therapy for OCD. But in addition, we use antidepressants, same as some of these other things, but we use them in different doses, at much higher doses for OCD. So it really does require some specialized knowledge to treat OCD.
but good to be on the lookout for. Okay, we're going to talk about all the different things we can do to help this, but I took a peek at the Q&A and I feel like we should just do some defining terms that we haven't done. So what is menopause? Menopause is the final menstrual period after a woman goes 12 consecutive months without a period. So it's a retrospective diagnosis. But we are spending a lot of time talking about that perimenopause, which can be many years leading up to that final menstrual period. The early stage, there are some subtle changes in your menstrual cycle that can go on for 5-7 years. And then the final stage where the cycles space out more go on for maybe 1 to 2 years. And that's really the time we're talking about with hormonal fluctuations. So for some women, it's shorter, but it can be maybe 7 years of these hormonal fluctuations. Don't despair, it doesn't have to be that bad, but it's not an overnight thing.
Yeah.
Go ahead.
Well, I was going to say, and that one of the things that Dr. Loeb and I probably do routinely is if I get a patient in who's complaining of things that might be consistent with a perimenopausal presentation, as long as that patient is at least in her late 30s, I'm going to ask questions that are going to lead me to discover whether that's part of her presentation. And that's something that I think doctors who don't specialize in menopause aren't aware of. So you really have to have that broad lens.
And so that was the other question. So what's the normal age? So the average age of the final menstrual period is about 51 and a half, but a normal range is about from 40 or 45 to about 58. So it's early if it's 40 to 45, but it's normal. And 45 to 58 is really like the range of normal for menopause. So just good to define some definitions. I'm sorry we didn't do that earlier. Okay, let's talk about what we can do, because like I said, don't despair. There are things we can do. I think let's start with sort of the real natural things. How can we change our diet?
Yeah, great question. And diet makes a big difference in the perimenopause. It's not going to necessarily, changing your diet isn't necessarily going to solve all of your problems, but it's great to think about healthy diet changes that you can make, particularly primarily plant-based diets. There is a weight change that goes on in the perimenopause that's there whether you like it or not, and changing your diet, however, can have some effects on that. So concentrating on Mediterranean diet, healthy plant-based diet is definitely going to benefit everybody. We'd like to think that perhaps having more anti-inflammatory foods might be helpful, but people talk about that. I don't see a huge amount of evidence yet that it's really going to be helpful.
Yeah. And you talk about weight doesn't necessarily have to go up, but the weight definitely shifts. And
it shifts.
That midriff weight is what so many women complain about, no matter what their weight is, skinny and not skinny. And some diet modifications that you spoke about, especially eating more plant-based and fewer carbs, can, number one, make you feel better. Number two, help some of that weight shift for sure.
Right. And can help with energy, which is another problem in the perimenopause. When if you're having mood disturbances, you're having sleep disturbances, you're going to have a low energy, and changing your diet can really help with that.
Absolutely. Less caffeine?
Definitely less caffeine and less alcohol. Both of those can really contribute to both the sleep disturbance that people have and also mood issues. Alcohol is something that people think of as soothing and calming, but not in the long term. And so that can really, if you're having any kind of mood disturbances, cutting down on the caffeine and alcohol can really help.
And of course, quit smoking with it for many, many, many reasons, right?
Absolutely.
The role of exercise in your mental health.
Yeah, exercise has a huge role, and there have been studies in the perimenopause specifically looking at both aerobic exercise and yoga for perimenopausal mood symptoms, and positive studies that do show that it helps. So I absolutely encourage everybody to do that. Particularly important, not just for the mood, but also remember what's happening in menopause is your estrogen is leaching out of your body, and that's going to have effects on your bones and your strength going into the older parts of your life. So if you're not somebody who exercises, the menopausal transition is a great time to develop an exercise routine that can benefit not only your mood, but also your physical health for years to come.
So, and you mentioned yoga, and I also believe mindfulness is such an important part of this.
Absolutely. And there's some good data about mindfulness meditation and its help in menopausal mood symptoms. Yeah.
Another important thing I think is to maintain social connections.
Absolutely. We know that people who have lower social support are at greater risk of mood symptoms across the perimenopause. So maintaining social connections is really important. I'm conscious of the fact that you and I have just recommended a bunch of things that take time. And one of the things we mentioned in this, as you called it, the silly putty generation, is that time can often be challenging for people who are balancing career and family responsibilities. But I think it's really important to prioritize that and to take the time to do things for your self-care, both in terms of your physical self, like exercise, and your emotional self, like social connections. Yeah.
Absolutely. I totally agree. I mean, when I talk about mindfulness in my practice, I'm not even asking for more than 5 minutes a night. But if you can go to bed, before you go to bed, do 5 minutes of a meditation practice or 5 minutes of yoga stretching, but something where you're tuning out the rest of the day, it helps you have a more restful night and therefore can help anxiety and all the other mood things going along.
Yeah, and mindfulness is something you can start really simply. You can say, I'm going to mindfully brush my teeth today. And, you not even take a meditation, but say, I'm going to just take this moment and be aware of that toothbrush and aware of what I'm doing now. And if you start out with something little like that, you realize that it doesn't take that much and you can then expand from there.
Yeah. And then you mentioned this with regards to OCD, the role of therapy, but cognitive behavior therapy, big, huge role for all of these mood disorders, right?
Absolutely. So psychotherapy is incredibly important. And, we have really good evidence for cognitive behavioral therapy. There's another type of therapy that I really like in the menopausal transition, as well as at other times of reproductive depression, which is interpersonal therapy. Interpersonal therapy is for people who are having some mood disturbance that is somehow related or connected to their interpersonal connections. And it focuses a lot on role transitions or role disputes. So a role transition is something that happens to everybody in midlife. You may have children who are growing up and going off to college. You may not have children and be realizing you're ending your reproductive potential. That's a role transition. You may be having a different relationship with your partner, that the changes in sexual function that we talked about. So there's lots of transition going on, and interpersonal therapy can be really helpful with that. But the most important thing with therapy, what's been shown over and over, is that it isn't so much the modality that matters. It's the connection that you make with a therapist. Having that alliance with somebody who can provide support to you in this time is the most important thing.
Such a great point. Okay, I'm always kind of weary of supplements, but I know there are some that are pretty well studied, and maybe you want to talk about those.
Yeah, and I think it's something that's really important for us to be knowledgeable about, because a lot of patients are really interested in it. A lot of patients who are trying to live a healthy lifestyle and feel that they don't want to take medication if they don't have to. Are there supplements they could use? Well, I wish that I could say that we have very strong evidence about a lot of supplements. The reality is we don't. We have a little bit of evidence, and the evidence that we have shows that there may be some benefit for some people using evening primrose oil, some evidence for chasteberry, which is another herbal supplement, and a bunch of others have been tried. There was recently a trial that looked at a combination, so combining evening primrose with chasteberry, with black cohosh, and with a phytoestrogen in one product, and that seemed to have a positive response on mood symptoms. But the problem is that we're at this point where there are a few small studies. We don't yet have a lot of data showing us how helpful this is. And because these are not FDA regulated products, you may get a very different formulation if you go to this health food store versus that health food store. So what I always say to patients is talk with your physician about it. And if there's something that you think may be helpful to you and it's not interacting with other medications you have, and it's in one of these categories of the supplements for which we have some data, which I would put evening primrose, chasteberry, black cohosh, then go ahead and try it and see if it's helpful to you, as long as it's not interacting with other medications. But don't assume that we have evidence that shows this is going to be the thing that's going to help. And if you're really having a serious depressive episode, it's probably wiser to stick with something over which we do have some evidence and that has FDA approval that's really regulating the doses that are going into that.
That's such a good point, and I think it's so important what you said, that you should really be telling your provider all of the supplements you're taking, because they can interact with other medications or to alter your blood levels of certain blood tests. And so to
Absolutely.
really, they're not always as benign as we think they are. And so that's really important. That's why I said I'm weary. Omega-3?
Omega-3, I would love to think that it really helps, because it's not going to hurt, and it does have good effects, we know, on heart health. We don't have strong evidence that it's really going to help mood in the perimenopause, but this is one for which we do have evidence that there aren't really harmful effects. So if you want to take an omega-3 supplement, go for it.
Okay. And then after all this, or in addition to all of this, maybe we have medications, right? So we have antidepressants, anxiolytic medications, and then we have hormone therapy. Let's start with the first group of medications.
Antidepressants, yeah.
Yeah.
And so the thing that I really like to emphasize when I talk to people about the use of antidepressants for perimenopausal mood changes is a lot of patients will say to me, but if this is a hormonal cause, why can't I have a hormonal treatment? Why do I have to take that mental health medication? To which my response is, it may be a hormonal impetus that got you to this place, but what matters is that you are in this place and that we have a medication that can treat those symptoms, regardless of what the impetus was that got you to that place. And the medications that we use to treat depression are relatively benign medications in terms of they don't have a large burden of side effects. They don't have, long-term risks to them. They're not medications that you become tolerant to over time. So they really are they're pretty effective medications. Does everybody respond to the first antidepressant? No, unfortunately, no, but many people do. And so because they are in that category of relatively low risk medications, they're the first thing to start if your symptoms are primarily mood symptoms that you're dealing with. In addition, some of the antidepressants can also help some of the vasomotor symptoms. So one antidepressant, paroxetine, is approved by the FDA specifically for hot flashes. And there are 3 or 4 other antidepressants that also have been found to be effective for hot flashes, even though they don't have that FDA label on them. So you might be able to kill 2 birds with 1 stone by taking an antidepressant that would help with both of those things. And as I mentioned, they're relatively low risk medications with relatively few side effects.
Yeah. And I mean, it's just what we spoke about at the beginning. It's the same part of the brain. So it makes sense that these medications would work in doing both. Those are great options for women who, for one reason or another, can't use hormone therapy. And we'll talk about that in a second. But one of the biggest concerns I always get about starting antidepressants is weight gain. Can you speak about that for a minute?
Yeah, and I think that's something that's such a concern for a lot of people, particularly in the perimenopausal transition, when there already is that weight shift that you mentioned of weight shifting to the midriff. And I think people are a lot scared of that. There's no question that there is some weight gain that can be associated with some antidepressants. The amount of weight gain is actually very small. It's on the order of about 2 to 4 pounds on average for the SSRI antidepressants. But for some people, that's too much, right? But we don't know who's going to be affected by that weight gain, because I would say of the majority of patients that I've treated over years on antidepressants, the majority of them do not gain weight. Some people do. So my feeling is, if you're really having a difficult time with depression, if an SSRI is indicated because of that, give it a try. And if you end up being one of the people who starts to gain weight on that, there are other antidepressants that are more weight neutral that could be switched to. There are other things that we can do to combat the weight gain. But I think not treating the mood could in the end have even worse effects on weight than treating it with a medication that has a relatively low amount of weight gain associated with it.
Terrific. All right. And then hormone therapy. So we've done webinars on hormone therapy. We will do more. So we can't focus entirely on it. We know the FDA indications for hormone therapy are for hot flashes and night sweats, for the prevention of osteoporosis, and for vaginal dryness. Those are FDA approved indications. We know it helps mood. We know it can. We don't typically start hormone therapy only for mood, but we know that it has a mood effect. And actually, the combination of hormone therapy and antidepressants is more than 1 + 1 actually equals 3. So they work really well together if that's what you need. Do you want to speak to that a little bit?
Absolutely. So I think, you know, hormone therapy for years has had a bad rap because of what everything went on with the Women's Health Initiative study. But when it's used for the short term around the menopausal transition rather than years later, the safety risks are much lower than people at one time feared they were, and it can be incredibly effective for the physical symptoms of menopause. So I definitely advocate it for that, and I do think it can be helpful for mood. The reason I wouldn't start hormone therapy for somebody whose major complaint is mood, even for somebody whose major complaint is mood and a little bit of hot flashes, is that while it's much less risky than we used to think it was, it's actually more risky than an antidepressant. So if your major complaint is mood and maybe you have a few hot flashes, we have antidepressants that can deal with that, and they are less risky long-term drugs. But if you are having significant physical symptoms along with mood, then menopausal hormone therapy is absolutely indicated, plus minus the antidepressant, depending on your symptoms. And I strongly advocate it for people.
Thank you for saying that's such a great point. Okay, this is probably the most important question. What advice can you give our partners or those close to us when we are going through menopausal changes and the mood swings?
Great question. And I think it's something that it's going to take a lot of encouragement for people to change in this way. I think when women have mood changes that are associated with reproductive transitions, in our society, it's something to make fun of. Oh, she's on the rag, right? She must be getting her period. That's why she's being so irritable today. And similarly in the menopausal transition. And I don't think that that's helpful to women going through this. And I actually think that society at large really downplays what a significant transition this is and how many symptoms it can be associated with. I mean, it can be really debilitating for people who are experiencing a heavy amount of symptoms. And even for people who have only 1 or 2 symptoms, what if one of those symptoms is sleep disturbance? You're not sleeping, the whole rest of your life is going to be off, right? So I think it's really important for partners and people close to us to acknowledge that, to understand that it's something real that they're going through, just as if they had, something else affecting their health or body, that it's something that they need to go through. And partners should say, how can I help? Don't make fun of the person experiencing it. Don't get ticked off because she's particularly irritable today. Don't laugh at her because she's sweating and she needs the window to be open. Instead, be supportive. Say, how can I help? You're going through something rough that I don't have to go through. What can I do to help?
That's great advice. Thank you. So I've been looking through the questions that have come through. I'm going to ask you for a take-home message. So I'm going to look through some of the questions while you're thinking of your take-home messages. But I think a lot of them are specific to menopausal symptoms, which we've addressed in other webinars. We do have a menopause center at Cornell. I see patients, and I work with Catherine Iarardi, who's our nurse practitioner, who sees patients specifically for menopause consults. So for your specific menopause questions, look at our website, and perhaps we can help you. But what are your take-home messages?
I will tell that, but I actually see one question in the chat that I really want to answer. Okay. I may do that before my take-home messages, which is a question about bioidentical hormones. And so I think that's I get a lot of questions from patients on bioidentical hormones, and I really want to address that because I think that came out, the push for bioidentical hormones came about at the time that people were concerned about hormone therapies that had the FDA approved level of estrogen in the wake of the Women's Health Initiative study. And so all of these bioidentical hormones rose up that had lower levels of estrogen and therefore weren't considered menopausal hormone therapies. Just like with the supplements, those are not regulated substances, and they therefore therefore we don't necessarily know how much of any kind of hormone is in them. So I would strongly encourage working with your provider to see what are those, what the things that you want to use, what do they have in them? How can you work with your provider to make sure that there's a real understanding of what it is you're taking and what it is you're taking it for, because the medications that are approved by the FDA are going to be safer than those. So I think that's a really important point.
Yeah, and I speak to that a lot too. Thank you for bringing that up. I didn't actually see that question, but the hormones that we prescribe that are FDA approved are biologically identical to the hormones that our body produces. And those bioidentical that people are referring to are those that are compounded in compounding pharmacies. And we're not actually sure 100% what's going into those. And so we prefer to prescribe, as Dr. Osborne was saying, the FDA approved ones that are, again, biologically identical to our body's hormones.
Yeah,
and come in many different strengths. So lots of ways to do it. Yeah,
exactly. But in terms of that, back to your question of my take-home messages, I think my big take-home message is for people to shout it out to the world that menopause is real, that menopause has strong effects on our bodies and our minds. It's not something to be ashamed of. It's not something to hide away. It's something to really address and embrace as a part of life that you're going through, but also seek out the help that you need. I have a colleague who is a wonderful physician who said that she's started just bringing it up in every single conversation. She talks to somebody who hasn't completed his part of an assignment he was supposed to do, and he has an excuse, and she says, but I'm in menopause and I did my part of the assignment. So I think that embracing it and talking about it is the way that we get more people to pay attention to it. I think doctors are very unaware of it. Doctors who don't specialize in menopause will never remember to ask about it if a woman in midlife presents, and we really need to increase that awareness among doctors. And one of the ways we can do that is for people going through menopause to constantly bring it up and constantly seek help and attention for it.
Thank you for that. We are kind of lucky going through it right now because menopause is having its moment. It's in the New York Times and lots of articles about it. So we've come a long way, but you are so right. It is normal. It is what the body is supposed to do. So let's embrace it and kind of find ways to feel good, feel well during it, right?
Yeah, absolutely. Yeah.
Yeah. Thank you so much for being with me this evening. Really informative, I think, and amazing to be with you. So thank you very much. And thank you all for joining us.
My pleasure.
Have a great evening.